So at the EHA 2022 meeting, we presented data combining Magrolimab with Azacitidine in frontline TP53-mutated acute myeloid leukemia. This is a population of very high unmet need, with the median survival with intensive chemotherapy, azacitidine alone, and even with venetoclax of about 5 to 7 months. So we have seen in the phase 1b study in the subset of patients with TP53-mutated AML treated on the combination of azacitidine and magrolimab, encouraging response rates and overall survival. That was with an initial subset of about 25-30 patients. And then this year at the EHA meeting, we presented the updated data set, 72 patients, and we're seeing an overall response rate of about close to 50%, with a CR rate of close to 35%, including half of those CRs with MRD negative by flow. So all in all, that's pretty encouraging, better than what's been seen with azacitidine venetoclax. Still remains a population of very high unmet need and difficult group, but I think this is probably the best data we have seen in the TP53 mutated AML. And what was really interesting is that the median overall survival was close to about 11 months, which is better than we have seen with HMA alone, HMA venetoclax, or intensive chemo, and especially in patients who could get to stem cell transplant. Small number, but we're seeing those patients have a 1-year survival of close to 65%. And seems to be quite well tolerated. So I think that the path would be to treat these people with azacitidine, magrolimab, try to get them to transplant soon, do some post-transplant maintenance, and then maybe we will have a shot at potential long-term remission and curing even some of these difficult patients. And there's a randomized study looking at that exact question of azacitidine, magrolimab versus investigator choice of azacitidine, venetoclax, or intensive chemo, and that's ongoing.